Welcome to Welcome to the National Recovery Month Congressional briefing entitled How Recovery Support Services Save Lives. Our co-hosts for this event today are Senators Chris Murphy from Connecticut, Senator Lisa Murkowski from Alaska, Representative Paul Tonko in the House Addiction Treatment and Recovery Caucus, and our fearless leader, Third Horizon Strategies. I wanted to give you just a brief background on why I'm serving in this role today. I'm a principal at Capital Decisions and co-founder of the McShin Foundation. So Capital Decisions is a small government relations firm that has a special focus on addiction policy. And the McShin Foundation is a recovery community organization in Richmond, Virginia, that has been around since 2004, providing recovery support services, housing, job training, and jail-based recovery support services. So I'm very pleased today. All of you are in for a big treat. We've got a great panel. We've got legislators who are key leaders in the addiction treatment and recovery area. We have Biden administration officials, including the US Surgeon General, Vivek Murthy, and he'll be providing a virtual talk for all of us. We'll be greeted live by the Assistant Secretary for Mental Health and Substance Use Disorders at HHS and the fearless leader of SAMHSA, Dr. Miriam Delphin-Rittmon. And we will also be joined by folks who are out there in the trenches doing this work, delivering recovery support services in a bunch of different ways to different communities. Rebecca Allen from CCAR, Kevin Schuler from CCAR, and David Whiters, who is with a new organization that he's going to tell us about and the work that they are doing. So we wanted to welcome everybody, and I'm going to kick things off. Our first speaker is probably known to everyone who is signed on today, but I'll give him a brief introduction anyways, because he's one of my favorite members of Congress to introduce. Congressman Paul Tonko is from the 20th District of New York, and he is a seasoned both state and federal legislator who has really made one of the core issues he works on that's really, thankfully for all of us who work in this area, addiction and mental health issues. And he has championed these. He has been a prolific legislator in terms of actually enacting legislation that helps those with mental health and addiction problems. And he'll probably tell you a little bit about some of that legislation that he has before us. He has been a leader for people in recovery, people in or seeking recovery, and their family members, and has done this work for decades. So welcome, Paul. Thank you so much for joining us today, and I'll turn it over to you.
Thank you, Carol. And thank you for your kind words and introduction. And I so appreciate you and your leadership within the addiction mental health arena. You're powerful, and it's just joy to work with you and to know that you put so much passion into getting this work done. So thank you for that. And thank you for inviting me to join with everyone today for this important discussion during National Recovery Month. As vice co-chair of the Addiction Treatment and Recovery Caucus, and from my own personal experiences in the capital region of New York, I have witnessed how very critical recovery services are to our given communities. I thank Friends of Recovery New York for their commitment to saving lives and for guiding me so that we can better work together to support these services. I fully understand that the more recovery service capacity we have, the more lives can be saved, certainly through access to these services. So I'm very proud to have led a letter this year asking appropriators to include a recovery support set aside in the fiscal year 2022 labor HHS bill as part of at least a $1.65 billion funding increase to the Substance Abuse Prevention and Treatment Block Grant. This exact proposal was included in our president's budget. I was happy to see that House appropriators heeded this call, and substance use treatment was funded at $5.5 billion, an increase, mind you, of $1.6 billion above the fiscal year 2021 enacted level, including continued funding for opioid prevention and treatment and recovery. It also would create a new 10% set aside with the SABG to support recovery services. If funded, the set aside would provide the first dedicated funding stream for recovery-oriented support services. It is more critical than ever that we deliver the resources needed to combat the disease of addiction and help countless struggling Americans find and follow their path of recovery. And I look forward to learning from today's discussion and continuing to collaborate and support recovery. Certainly, the work that we need to do to address populations that are at high risk, incarcerated individuals, that we've been working with our Medicaid reentry bill. I'm continuing to push forward with that effort. Want to make certain that those individuals who have been projected to be 129% more vulnerable to die of overdose are absolutely responded to. So with a requirement of a 30-day notice coming with release, there will be programs, if our bill passes and gets signed into law, that will enable people to be tethered to a system. Comes in so appropriately well at a time when COVID is impacting every rank of population out there, including those who are incarcerated. We have a lot of work to do. We're going to continue to pound away at taking this work across the finish line and making certain that with dignity, with respect, and with substance and correct policy, we will address the needs of so many people who are relying on the good work that we need to do. With that, I wish you well with the gathering today, and keep me informed on what we can do to continue the battle to do the right thing. Thanks, Carol.
Thanks so much, Congressman Tonko, and thank you again for your leadership, your commitment, the work ahead that you've done in this session on the recovery set aside issue. We thank you. We believe in you, and you can rest assured we'll be back in touch as things develop. Thank you.
Yeah, I count on that. So thank you. We need it. It's
you
great.
Bet. Thank you, and thank you for your whole team.
Oh, my pleasure. Well, I'll let them know.
Okay, very good. Well, our next panelist is going to be someone who many of you, who might be a new face to some of you, but certainly not to many of us who have had the opportunity to meet her. Dr. Miriam Delphin-Rittmon is the new fearless leader. She's the Assistant Secretary for Mental Health and Substance Use at HHS, as well as the administrator of the Substance Abuse and Mental Health Services Administration. Dr. Rittmon previously served in the role in the state of Connecticut for 6 years as the commissioner of the Connecticut Department of Mental Health and Addiction Service, and served in that role for 6 years. We learned of her great work through our colleagues in Connecticut, again from CCAR, who, as I mentioned, some of their team will be speaking later on in the briefing. But Dr. Rittmon was supportive of recovery support services in creating a recovery-oriented system care in the state of Connecticut before we were lucky enough to get her to run SAMHSA. And we are so pleased that she's able to be here with us today. And without further ado, I'll turn it over to Assistant Secretary, Dr. Miriam Delphin-Rittmon. Dr. Rittmon, please unmute and share with us today.
Okay, thank you so much, Carol. I appreciate that introduction, and good afternoon, everyone. And thank you to the Congressional Addiction Treatment and Recovery Caucus co-chairs, Tim Ryan and Representative David McKinley, and other members of the caucus for inviting me to be here during this roundtable. I also want to say a special thank you to Greg Williams from Third Horizon, who is an incredible recovery advocate from my home state of Connecticut, for including SAMHSA in this important event. I'm excited to be here with you all this afternoon to discuss the very important topic of recovery supports. SAMHSA's core mission, as you know, is to reduce the impact of substance use and mental illness on American communities. And since being sworn in this summer, I've identified 5 core near-term priorities that I would like SAMHSA to tackle during my time as Assistant Secretary. These are preventing overdose, enhancing access to suicide prevention and crisis care, promoting children and youth behavioral health, integrating primary care and behavioral health care, also using performance measures and data and evaluation. Today's discussion on recovery supports aligns with these priorities, and recovery cuts across each of these as a fundamental principle of our work. Several of SAMHSA grants provide funding in the area of recovery. I'd like to share information on our recovery support programs and examples of some of the outstanding activities and accomplishments that have been reported by SAMHSA grantees. So for example, the Recovery Community Services Program has provided peer support services since 1998 via recovery community organizations who value the experience of people with lived experience. These services are integral to the process of recovery. From 2016 to 2021, grantees have conducted 756 intakes into their program and demonstrated positive rates of change from intake to six-month follow-up in most of the national outcome measures. The national outcome measures that are used include individuals who have abstained from use of alcohol or illegal drugs, had no arrests in the past 30 days, have current employment or are attending school, experience no alcohol or drug-related health, behavioral, or social consequences, have social connections, have a permanent place to live in the community. This program also achieved positive outcomes in reducing mental health issues, risky behavior, and physical health consequences. Rutgers University, a Matt Padoa grantee, reported that since its initiation of the Peer Navigator Specialist Program, there have been a 22.4% increase in the use of buprenorphine among participants. In addition, naloxone or Narcan kit distribution has increased by 379%. During the pandemic, the program noticed a sudden decrease in buprenorphine utilization and deployed peer specialists to allay fears and keep clients engaged in treatment. Thanks to the Comprehensive Addiction Recovery Act, the Building Communities of Recovery, or B-Corps grant program was born. This grant program mobilizes resources within and outside of the recovery community to increase the prevalence and quality of long-term recovery supports. The projects that are funded to support development, enhancement, expansion, and delivery of recovery support services. During the period from FY 2016 to FY 2021, the program conducted more than 267,000 intakes and demonstrated a positive rate of change from intake to 6-month follow-up on all national outcome measures. One of our largest programs at SAMHSA, the State Opioid Response Grant Program, continues to implement innovative activities that have increased the number and availability of comprehensive prevention, treatment, and recovery support services that address often complex and multifaceted clinical and psychosocial needs of those of opioid use disorder or stimulant use disorder. Through the SOAR grant, more than 508,000 Americans have received recovery services and supports. I'd like to call your attention now to a few outstanding recovery support activities that have been implemented through the SOAR grant. As part of a full continuum of care, for example, Arizona implemented a rapid rehousing model to provide rental assistance to individuals entering opioid use disorder or stimulant use disorder treatment who have limited income for safe or secure housing or who have not met the criteria for traditional housing. And from my home state of Connecticut, CCAR uses the CCAR program, uses the SOAR funds to support on-call recovery coaches in emergency departments across 21 hospitals. Members of the CCAR team are here today, so you'll hear from Rebecca Allen and Kevin Schuler, who just do outstanding work in terms of connecting people to services and support. So it was a pleasure to work with them when I was in Connecticut. Vermont, through their specialty recovery coaching program, has trained and educated recovery coaches to serve specialty populations. In 2020, recovery coaches convened specialty recovery groups with clients who identify as deaf and hard of hearing, LGBTQ, and Black, Indigenous, and people of color. 13 organizations in Pennsylvania utilize SOAR funds to deliver employment services to individuals in recovery from opioid use disorder. New Jersey's support team for addiction recovery, or STAR program, for instance, assists individuals with opioid use disorders, such as with homeless services and supports, incarceration, legal help, employment, education, and transportation services and supports. In addition to grants, SAMHSA is finding more and more ways to support recovery. Two of our newest resources include the Recovery Housing, or Best Practices and Suggested Guidelines, and the Evidence-Based Resource Guide, Substance Use Disorders, Recovery with a Focus on Employment and Education. Both of these resources can be found on our website. And we're also working to partner both inside and outside of government. For example, in 2019, SAMHSA started the USDA partnered with USDA to create the Addiction Recovery Transitional Housing in rural communities. Also in 2020, SAMHSA established the Peer Recovery Center of Excellence. It's housed at the University of Missouri, Kansas, and provides training and technical assistance to build recovery community organizations and enhance professionalism among peers throughout the workforce. I would like to close today by discussing the President's FY22 budget proposal for a new 10% set aside within the substance abuse block grant for recovery support services. This set aside will build upon more than 2 decades of practice-based research that began when SAMHSA awarded the first recovery community service programs that I mentioned earlier. This set aside will help to increase access to recovery support services across the country and complement the existing efforts to respond to the ongoing overdose crisis that is accelerated during the COVID-19 pandemic. Again, thank you so much for inviting me to be here today to discuss SAMHSA's programs and initiatives around recovery supports. I look forward to this discussion and will be happy to have questions and discussions as we continue on. Thank you.
Thank you so much, Dr. Delphin-Rittmon. And as an educator and an advocate in this area, I hope all of you who are tuned in notice that our new SAMHSA administrator brings her whole heart and her head and mind and numbers to the work that she does. I listened with admiration as she gave us very specific examples. She didn't use a bunch of jargon and a bunch of acronyms that regular people don't understand. And she gave specific data points to bolster the case for the efficacy of these services. So a great person that many of us look up to. And we very much appreciate you modeling what good education and good advocacy looks like. So thank you very much. And thank you for sticking around to answer some questions. We really appreciate that. Next, we are going to hear virtually from Senator Lisa Murkowski. Senator Murkowski is a member of the Health, Education, Labor, and Pension Committee. She's also a member of the Senate Appropriations Committee and also works on other committees that are important to her state, including Energy and Vice Chairman of the Select Indian Affairs Committee. Most importantly, Senator Murkowski has been quite a friend of recovery, both in her state and in the country at large, and is working on legislation as we speak that I'll be interested to see if she talks about, but you'll be hearing about it soon within the next month or two if she doesn't talk about it in her video. And so with no further introduction needed, let's bring on Senator Lisa Murkowski.
Hi, I'm U.S. Senator Lisa Murkowski. I appreciate today's focus on recovery support services for those who suffer from addiction and substance use. And I want to extend a special thank you to all the providers and advocates who continuously work on educating the public about and promoting recovery support services. COVID-19 has created unique challenges, and I am inspired daily by all those who are creating unique solutions with limited resources. Historically, recovery support services have been underfunded at the federal level. Acute care or intermediate treatment is crucial for individuals who suffer from addiction. But without long-term recovery support services, we know that relapses will happen. And this creates a relentless cycle which often can impact not only those who face addiction, but also their loved ones and even entire communities. Comprehensive services such as peer recovery support services are pivotal in the recovery process. Congress needs to take action to ensure all Americans, including those living in rural areas, have access to these services. Unfortunately, COVID-19 has exacerbated many of the challenges that were already being experienced around the country, including alcohol and substance use. Standing up emergency services and programs for substance use and mental health was critical during the pandemic. But we also need to be thinking about long-term services for individuals that need them. There's a tough road ahead for those working to address the mental health impacts of this pandemic, including increased substance use. But together, we can give these individuals and their communities a path to recovery. I continue to hear from constituents and stakeholders about how impactful recovery support services are, especially peer-to-peer recovery services. Having a strong support system to help navigate the journey to recovery has proven to be crucial. In Alaska, 80% of our communities are off the road system, and the majority are lacking access to comprehensive detox centers and recovery services. It can be so disheartening to visit small remote communities and to see firsthand the challenges they face and to see the need that they have for support to help community members that are struggling with addiction. So I've made it a priority to increase access to treatment services for those who struggle with substance use, including expanding recovery services. I'm currently exploring legislative solutions to expand research in recovery support services and establish comprehensive substance use disorder peer workforces in rural areas. I've also supported increases to the Substance Use Prevention and Treatment Block Grant, as well as specific funding for SAMHSA's recovery programs. I really hope that we can keep the momentum going on this effort as we look to finalize appropriations bills for FY22. Providing adequate funding for recovery support service is a priority. So again, thank you to the advocates and to the recovery support specialists for all that you do, all that you've done, and all that you will continue to do. Thank you.
Thank you, Senator Murkowski. And for all of you who are recovery support service providers, never forget that you have the focus, attention, and admiration of United States senators from all over the country who appreciate and value the work you do and are working every day on the key committees that we need them to be, to working to make the services you provide more available and hopefully scaled in a greater way to meet the needs of your community. The next federal official that we're going to hear from virtually is none other than our U.S. Surgeon General, Dr. Vivek Murthy. Many of you may remember that he was involved in the landmark Surgeon General's report during the Obama administration on alcohol, drugs, and health, which really provided a framework and a baseline that all of us use today and going forward for the work we do in the recovery space. It was one of the first times in a major national government-backed report where there was a whole chapter on recovery. And interestingly, it very much detailed all of the evidence that supports recovery support services of all kinds, everything from peer coaching to education to housing. So we're really lucky that he, in this new administration, has determined to stay engaged. He's someone that has personal experience in this area. He's a family member of someone affected and continues to be somebody that supports our issues even while in the middle of fighting a global pandemic of COVID. So let's all take a look and a listen to U.S. Surgeon General Vivek Murthy.
Hi, my name is Dr. Vivek Murthy, and I serve as Surgeon General of the United States. Thank you so much for having me today. Shortly after I began my first tenure as Surgeon General in 2014, I went on a listening tour. And as I traveled across the country, some of the most impactful encounters I had were with people who were recovering from substance use disorders. In their stories, I saw real strength and resilience. But I also saw how addiction had harmed families, friendships, and entire communities. And I came to understand how the entire experience of addiction could make many people feel forgotten and cast aside. In 2015, tens of thousands of people showed up on the National Mall for the first ever national rally to end the silence around this epidemic. People in recovery came to voice the pain of addiction. Their families and allies came to show solidarity, and they all came to advocate for the addiction crisis to be addressed at the highest levels of government. That rally was a tangible symbol of the yearning that people felt for healing and recognition. I had the opportunity to join that rally, and it was there that I announced our office would embark on creating the first Surgeon General's report on alcohol, drugs, and health. In 2016, we made good on that promise and delivered our Surgeon General's report to the nation. Our goal was for this to be more than a report. It was a call to action. It shined a light on the enormity of the addiction crisis. It offered steps we could take to support those who were starting or sustaining their recovery. And it reframed addiction not just as a crisis affecting some people, but as a moral test for all of us. Because we know that addiction isn't a character flaw. It is a chronic condition that we must meet with skill, compassion, and urgency, the same way we would any other chronic illness, like heart disease or diabetes. So we need to invest in a system that reflects that truth, a continuum of care that includes prevention, treatment, and importantly, long-term recovery support services. Evidence shows that with the support of community, people can manage extraordinary stress and adversity. And in the context of addiction, they are more likely to initiate and sustain recovery. That is why we need to dedicate significant resources to meet the needs of people in recovery, especially at this moment when the COVID-19 pandemic has isolated so many of them from their support systems. I know that if we invest in recovery support services, we will contribute to an incredible moment of healing, and we will respond with conviction to the moral test posed by the addiction crisis. Thank you for all that you do. My best wishes to you all.
Thank you. And many of you may remember that Dr. Murthy also, for the first time, sent a letter to every single physician in America recommending that they use naloxone, the overdose reversal drug, when prescribing it to patients on high dose opiates. And he really lifted up the use of naloxone across the board, whether it be, over the counter or prescribed by a physician. And we owe him a debt of gratitude. I think, the provisional data from the CDC shows in the last year, we've got over 96,000 deaths. And I think that number would have been tremendously higher if federal officials like Dr. Murthy had not gotten engaged in really medicalizing and making naloxone something that wasn't just whispered among people who have drug problems, but mainstreamed it in all of medicine, in all of society. So we owe him a debt of gratitude and continue to view him as a federal partner in this work. And we're fortunate to have him as that. Our next speaker, who we are pleased will be sharing with us in person today, is Congressman Anthony Gonzalez. He hails from the 16th District of Ohio. He serves on the House Financial Services Committee and has been a tireless fighter to combat the opioid epidemic in his district and in his state in Ohio. He also is among a growing group of people who are either currently or formerly in the National Football League who have been willing to put a face and a voice to the opioid crisis and to the alcohol and other drug crisis in general. And we're grateful that he's been willing to take on this issue in his public life as a public servant. And we hope that when he moves into the private sector in a couple of years, that he will continue to lift up this issue in whatever role he decides he's going to be serving. And so help me welcome Congressman Anthony Gonzalez. Congressman Gonzalez, please unmute and join us.
Thank you. Can you hear me? Did that work?
It sure did.
Wonderful. For those of you who have young children, you'll sympathize. I had a nice quiet setting in my house from which I was going to speak with you. And then my kids woke up. So here I am in the car. I hope you'll bear with me.
Absolutely.
Thank you. As was mentioned, this issue is very personal. It's personal to my district. Ohio has been the center of the opioid crisis for many years, but it's also personal to me from my NFL background, as many of my own teammates have struggled with substance use disorder at various points, either while they were still playing or once they've transitioned from the game. And few issues are more overwhelming and more in need of our attention than this crisis that is ripping through so many of our communities throughout the country. And for many Americans, the pandemic has uprooted their personal lives, causing hopelessness, isolation, desperation, and outright despair. There's no doubt that the deep fragmentation in our culture, decline in key institutions, and growing isolation in the age of social media have contributed as well. Unable to find positive ways to cope, more Americans are pivoting to alcohol and drugs than any time in recent memory, tragically. According to recently released data from the CDC, there were over 93,000 overdose deaths last year, the most in our country's history. Next year's numbers could be higher as more and more live each day under the burdens of addiction. These symptoms force us to ask the question, how can we as a society respond to this crisis? While the question itself is not complex, it does not lend itself to simple or easy answers, nor will I pretend to have them today. We begin by recognizing the crisis we are confronting, which at its most fundamental level is a crisis at the interpersonal level. As I mentioned at the outset, it's a crisis of hopelessness in many respects, and these are most effectively answered at the community level, where people can see each other face to face. For those of us who've been through therapy, whether it's for drug counseling or therapy of any kind, we know that face-to-face interaction is invaluable and in many ways can't be replaced. And so this doesn't necessarily entail shifting political power from the federal level to the local level, but rather empowering our local institutions, whether that's civic, religious, educational, medical, to play a greater role in supporting those among us who are struggling the most. An anti-addiction effort won't be effective in my eyes unless it's part of a broader effort to restore our social and economic institutions at the local level. In other words, to restore hope. It requires finding ways to bring people together to address the problems where the problems are most acute. By no means does this mean a renewal of localism will solve every problem, though I think it helps, nor does it mean that Congress has a limited role to play. In fact, now more than ever, Congress must find ways to empower communities and ensure they have the resources to help Americans both meet their needs and be more needed. To that end, I've helped lead legislation along with my friend Congressman Tonko from the other side of the aisle that would eliminate the X waiver and help millions of struggling Americans again gain access to buprenorphine so they can begin their recovery sooner. I'm also pleased to see the introduction of Congresswoman Spanberger's Support Recovery from Addiction Act, which would ensure states set aside 10% of their substance abuse block grant programs for recovery support services. These policies are simple ways that Congress can empower our communities, providing them tools and resources and ensuring they are delivered with a human touch. But this is by no means a complete solution, and my belief is the journey never truly ends. We must remain vigilant, we must remain empathetic to the needs of our community and to those who we're so fortunate to serve. Thank you for the opportunity to speak with you today. God bless you all, and God bless the work you're doing. Thank you so much.
Thank you. Thank you so much. And I want all of you to note that it is not by accident that we have gathered a bipartisan group of legislators to help support this work. And many of them support each other's bills that help advance the work we do. And we are hoping that we can continue to be a model for the country and keeping our issue purple and moving the country to find solutions where both sides of the aisle can agree on. And we're proud and hopeful that Congressman Gonzalez will continue to be the strong champion that he just explained himself to be. So we're thankful and grateful that he joined us today. We're going to switch gears a little bit now. We're going to go from our elected and administration officials to get a little bit more into the weeds. We're not going to make your eyes roll back in your head, but we are going to get into and we want to thank our congressional staff who have joined us today, we want to get into the weeds a little bit on what are recovery support services? How are they financed? How effective are they? And we couldn't have picked a better person to get us started on that path for the rest of the briefing than my colleague and friend, Greg Williams. Greg is the managing director at Third Horizon Strategies, and he leads the Alliance for Addiction Payment Reform, a national collaboration aimed at improving outcomes for patients, payers, and health systems. Greg is also the award-winning filmmaker, as many of you know, of feature-length documentaries, including The Anonymous People, Generation Found, and a soon-to-be-released new film, Tipping the Pain Scale. In 2015, Greg produced the historic Unite to Face Addiction rally on the Mall that you heard Surgeon General mention, where tens of thousands of people from around the world gathered alongside major musicians to end the silence surrounding addiction. So most of you know Greg, and he really doesn't need introduction, but there you have it, and I'll turn it over to Greg.
Thanks, Carol. Thank you so much. And thank you for the mentorship, the leadership, the friendship through the years. I don't think I would know much about recovery policy if it wasn't for you. And so I appreciate you leading us through this journey. And thank you to everybody today who's joined us and the bipartisan members of the House and Senate who have joined us, as well as the members of the administration who have joined us in support of Recovery Month, National Recovery Month. It's always an important time to put a face and voice on recovery. And so today, I wanted to kind of start with just my own personal journey of long-term recovery. Started in the community, and so I, found recovery after treatment and recovery housing, and I'll talk a little bit about that. But I've sustained my recovery in the community, and it wasn't for 4 or 5 years till I was introduced to William White's work that I kind of understood the difference of what many people are talking about today between treatment and recovery-oriented systems of care. And so I kind of wanted to start today with a William White quote that I just really think is the essence, and it's: the community is the soil in which alcohol and other drug problems grow or fail to grow, and in which the resolutions to such problems thrive or fail to thrive over time, just like Representative Gonzalez just said. The community is really where we can build recovery-oriented systems of care, and where recovery supports can help people sustain their long-term recovery. And today, we're really excited at Third Horizon and all the recovery community organizations across the country who've supported this work. We're releasing an important data set on recovery support services, an aggregate compendium of different kinds of recovery support services, and some new and emerging data that we're getting from local communities all across the country. And so this is now available on the website for free. We'll send it to everybody who is signed up for today's webinar, along with the recording, and we'll disseminate it broader. But hopefully we see this as not only a vehicle to help educate members of Congress as they consider the president's proposal that I'll talk about in a little bit, but it also, we believe, once implemented or states are implementing investments in increased recovery supports, can guide states to invest in different strategies and learn from what some states have done, what other states have done. There's certainly some really exciting data points in terms of the effectiveness and the value of recovery support services. So before getting into the specifics of the services, this notion of recovery capital, and that's how we kind of titled this brief, was that this notion of recovery capitalization and this investment in community and recovery capital. There's internal capital and then there's external capital. So when we work with somebody individually, therapeutically, to increase their internal capital, their self-esteem, a lot of people talk about this notion of somebody being ready to get help, somebody being ready to seek care or sustain their recovery. While there is some truth to that, absolutely, there are external factors that all of us can put and build and create in communities, just like alcohol or drug dealers or folks that feed on addiction create those social factors for people to find addiction. We can also create those same social factors for people to find recovery and sustain the recovery, and so that this notion of people can become ready and interested in seeking recovery earlier and sustaining their recovery longer. And so when we overlay this notion of social determinants of health, some similarities and some differences in terms of what we think about from Recovery Capital. And so this graphic from our colleagues at SR4 DIS really kind of help to articulate some of those similarities and differences, and really demonstrate. So in the education realm, for example, we have recovery high schools and collegiate recovery programs, which I'll talk a little bit about. Specific in healthcare, we talk about broadly access to healthcare as a social determinant of health, but specifically, do we have access to specialty SUD services and the like? And then social and community context, where peer recovery support and recovery community organizations. And so Recovery Capital in quantity and quality plays a major role in recovery success, and we can start to measure that, and we're starting to measure that and track that at the community level, not just people's internal capital, but the external capital that our communities can begin to create and help folks sustain their recovery. So to define a little bit of the different kinds of recovery support services, I wanted to take a flyover of some of the different styles. So when we say recovery support services, it's a broad collection of different kinds of things. And so we're seeing them be deployed in different ways. So the Recovery Community Center is a model that we have in about 150 communities in America, not enough, but community centers where, just like a senior center on Main Street, where recovery, it says Recovery Community Center, people can walk in, it's free. There's recovery support meetings. Recovery schools, I'll talk a little bit about, and that happens both at the high school and the collegiate level. And then you'll hear a lot about peer-to-peer recovery support services. Those are being deployed in a lot of different ways, creatively and innovatively, where they're non-clinical recovery support services. Employment services are huge. We know the employment crisis at all levels of society right now, coming out of the pandemic. And we need to find ways to employ, people in recovery, or people seeking and finding recovery. And then housing is this critical need where the recovery housing need is a little bit nuanced and different than the general housing crisis, and the style of housing is specific to the needs of people in recovery. So I just wanted to also call out one important concept as we dig into these recovery support services, which is, even after a year or two of remission, from alcohol or other drugs, it can take 4 to 5 more years before the risk of relapse drops below the 15%. So basically, as a person in sustained recovery for 20 years, my risk factor for generating a substance use disorder again is back to about the risk factor for the general population. That's not the case for people in the first 5 years of their recovery. And so what we really need to think about, and William White again articulates this really well, is just like cancers, we need to follow people, track people, and engage people for a sustained period of time, just like we do with most cancers, in order to have better long-term outcomes and long-term results. And we do a lot of this work at the Alliance for Addiction Payment Reform. How do we create financing systems to underwrite the longitudinal need for people that goes far beyond the 28-day programs or the outpatient programs that many of our communities do have in the infrastructure today. So recovery community centers, are operated in different communities. We call out here to Tom Coder from Rhode Island. This is the anchor that we got to film in the Anonymous People, but Recovery Community Centers, a couple different ones in Rhode Island, but across the country. And, they provide social events, connections to housing resources. A lot of them do telephone-based recovery support where they'll call people in recovery. They do community education, advocacy, and other service events. And these are kinds of institutions that don't have a traditional financing stream because they're for the community. They're for one-to-many. They're not one-to-one services that we often reimburse in the healthcare system. In 2021, a study in Ohio said the average engagement was 130 days, totaling over 4,000 engagement sessions. And then individuals had a significant increase in their recovery capital, the people that engaged in recovery community centers. So this is a great study. We write about it in the new brief here. Peer recovery coaching, I'll let Kevin and Rebecca talk a lot about this, but this is one of the fastest growing services across the country, and we're seeing thousands of recovery coaches coming into the workforce, but we need hundreds of thousands of more. SAMHSA released a report in December, that talked about how under capacity we have. And what's different about the peer recovery workforce from the clinical workforce or the psychiatric workforce is that the training, the onboarding, and our ability to bring on people into the recovery coaching field is a lot quicker, given the skill set and what people need. It's not to replace any clinical needs that people have, but while we have a real crisis in our workforce for behavioral health and for addiction, we really need to find strategies, as Senator Murkowski talked about, to really increase the workforce for peer recovery coaching and peer recovery coaches in all different settings, be it in prisons, via phones. You'll hear about emergency departments and in recovery community centers and the like. Housing is a huge issue, and we've done a lot of good work. The National Alliance for Recovery Residents has done a phenomenal job in terms of certification. We have a lot of local affiliates that have developed some specific elements of recovery housing. And we are very excited to find ways, and certainly ways that we could invest in housing in a more robust way for recovery. There's the Missouri Coalition of Recovery Support Providers had a great study in terms of how many houses they've been able to accredit and how funding through SOR was able to increase the number of recovery housings, and then the number of recovery houses that accept and support MAT, and increase the number of certified peer specialists in the state of Missouri. So it's a really important case study that we highlight in this brief. Recovery high schools is a passion of mine. I got into recovery at 17 and had no idea that these existed. We still yet to have one in Connecticut, and have been working for a long time to try to see if we can get one developed here. There are a number of them across the country, and we do see a lot of the funding support through the states support some of these schools. And we see higher graduation rates, significant lower odds of dropping out. And this is for a really at-risk population. So when we talk about the dropout, at-risk youth population, the population that these schools are investing in are really, really important. And then at the college level, we've seen some incredible growth over the last 4 to 5 years in terms of the investment of collegiate recovery programs. And the North Carolina experience is one of those bright shining lights about how a state chose creatively to use their federal funding and invest in university campuses all across the state. And so this gives you a nice little snapshot of the growth of collegiate recovery in the state of North Carolina. We dig into this in more detail in the brief. And as I mentioned, these services and supports can be delivered in lots of different ways, and you'll hear about a couple of those things in a minute. But the really exciting thing, I think, is about technology and what we can do with peer recovery coaching through recovery management applications, contingency management, Zoom-style recovery support meetings during COVID, asset mapping tools, and then secure asynchronous recovery supports. And SAMHSA has a great program, the RCSP statewide network, where statewide networks can organize recovery communities across the state, where there isn't really another dedicated funding stream for organizing recovery community organizations collectively in a state, other than that small program that we need to grow. And then the specific populations that are in need, whether they're justice involved, BIPOC, Latinx, Indigenous folks, LGBTQ, and faith-based, we need to tailor recovery supports to those specific populations. And then we get into a little of the funding of the last couple years. And so you can see in this chart of the block grant and the STR and SOR, the massive increase in the COVID relief funds in that dark blue there in 2021. But really exciting about the president's proposal in 2022 to try to not have that funding kind of go off a cliff, but sustain it. And so it's a good image to as we talk about a 10% set aside and thinking about increasing the investment in sort of a new element of the continuum at scale. This is our moment, right? This is our moment to do that, because we have increased resources. Every clinical service that we've been investing in, every prevention resource that we've been investing in would not see a cut in any of their funding. They'd see growth in addition to the set aside. So it's really important to kind of think about this conversation in the context of that increased funding growth for states and communities. And so I'll just end kind of with the budget proposal and what SAMHSA said in their budget summary, which was currently there's no dedicated source of funding for community recovery resources. As a result, only 150 communities have a recovery community organization. This funding set aside would provide a sustainable source of funding directly to community organizations to support development of community level recovery infrastructure, and will be available for a wide variety of recovery support programs. And one graphic that I've been using in our conversations on this, when we think about the opportunity to scale community recovery supports with 150 recovery community organizations. I mean, we have 435 congressional districts, 3,000 plus counties. We have 4,000 prisons and jails in America, over 5,000 prevention coalitions, and over 15,000 addiction treatment programs. Probably none of those numbers are enough, but certainly 140, 150 compared to these other numbers, I think gives you the sense of disparity between what we've invested in historically and where we need to apply some increased resources to invest in moving forward. And with that, it's my really excited pleasure to introduce you to an organization working on a really important need, the African American Federation of Recovery Organizations. And I'm proud to hand it off to Dr. David Whiters from, he's got 37 years of long-term recovery, and he's been involved in the addiction recovery advocacy movement since the initial meeting of the new recovery advocacy movement held in St. Paul, Minnesota, 20 years ago this year. And so without further ado, I will hand it off to my friend and colleague, Dr. Whiters.
Thank you so much, Greg. Good afternoon, everyone. And my preferred name is David. So if you want to engage me, please call me David. And I need Carol to remember the name of our organization. You may think it's new, but the thought of Afro has been around for many, many years. And we promise that will be a name that you'll be hearing from on a regular basis. We believe that the work that we're doing or trying to do to increase recovery support services in communities that are predominantly African American is important. So
My bad, David.
No problem. So we'll be around for a long time. But the next slide, please, Greg. Look, though the name Afro might be new, the conversations are not new. I can remember when the 4 or 5 of us who were part of the RCSP programs that Dr. Delphin-Rittmon talked about the CSAP funded in the early 2000s. I can remember when we sat over in the corner. It was only 4 or 5 of us. There wasn't very many, let me tell you. And we sat over in the corner and we had conversations about coming up with strategies that would increase the number of African Americans who could get access to recovery support services. Because what we were discovering is that these programs that were being successful at helping Black people achieve and sustain long-term recovery. So the next slide, please, Greg. Look, there's 23 of us. We have close to 300 years of sustained recovery. Not only do we work in the African American community and Black communities, but we live in our communities. And why that's important is because we object, is that an okay word, to those who come from outside our community who try to give the impression that they know better than us, better than we do what's best for our people. We're not all that open to accreditations that come from outside of our community telling us this is how we need to operate our services to be effective. We ask them when or where have you ever lived in the Black community? And unless you have that lived experience of living in this community, we would rather that you not try to give the impression that you know more than we do about what's best for the folks in our community. We've been providing recovery support services since the early 2000s. Some of us started this process in the late 1990s. Next slide, please, Greg. Just go to the next slide, because I want to show you how something that I guess this is a tribute. I don't know. I'm not a politician. I don't know a senator from a congressperson. That's not a strong suit of mine. That's not what I'm about. There are others among us who have experiences in those areas. But some of my colleagues objected to me using this slide because this slide makes the claim that President Biden and Vice President Harris are aware that Black people get sent to prison more often than they get sent to treatment. That there are more, that the gap in the years between the time a Black person accesses recovery or treatment is 4 to 5 years greater than that of a white person. Now, I can assure you this. My dissertation focused on recovery support services specific to Black people and Black communities. I can tell you in all my research that what I discovered, that the gap between the time when Black people access treatment compared to when white people was more like 12 to 14 years. So I'm not for sure where they came up with just 4 to 5 years, but this is what they claim. So the president is claiming that we know that Black people are being disproportionately incarcerated. We need to do something different about that. Well, let me tell you, this ain't a new argument for us. We've been knowing we need to do something different for Black people for a long time. And so I want to move past the slide because I get real passionate about that slide. And I started to point out some of his condescending remarks, but I don't want to go there. This is where I do want to go. Let me just focus on the reality let me focus on the realities that are taking place among African American substance users specific to COVID. This slide is a slide from heck because it asks you to do 2 things. It's asking you to read and listen to me at the same time. I'm just going to ask you to listen to me, and hopefully you can get access to these slides at a later point. But this is what this slide is saying. That because Black people were not accessing medication-assisted treatment at the same degree as white opioid users post the pandemic, that when the pandemic happened and we created all these innovative approaches to making sure that white people on medication-assisted treatment were getting access to their medication, we were neglecting and abusing Black people. So guess what happened? Let's go to the last paragraph here. It says, I want to go back to that slide. It says, in summary, our findings at a macroscopic level, those of us who are social workers know that means at the community level, provide evidence that substance use disorders should be considered a condition that increases risk for COVID-19, a comorbidity that has particularly, and that word there, you can replace it with fatal effects to African Americans, essentially what this is saying. Because we neglected and abused Black people prior to the pandemic, when the pandemic hit, a bunch of Black people who were using substances died and overdosed and died as a result of that neglect and abuse. Let's go, and that's what it is, it's neglect and abuse. If I'm a social worker, if I saw a person treat their children this way, I would have to report them to DFACS. Look, I want to talk to you real quickly about another COVID study that came out of Boston, from among some Boston medical researchers. It says that in 2019, for the first time, and this again is one of those condescending comments, It says for the first time, Black people die from overdoses at a higher rate than whites. Man, look, I'm gonna show you at the end of this slide here, that's bogus. Black people been dying at a greater rate than white people long before 2019, and we had evidence. The death rate among non-Hispanic Blacks, that's me, increased from 31.3 per 100,000 to 4.3.2 per 100,000 hours. That's a 38% increase. That's the rate of increase that Black people have been dying as a result due to COVID. Meanwhile, overdose deaths among white people have stayed level. Well, no, white people has decreased, while among Hispanics has stayed level. We have seen a slight decrease in the number of white Americans who've died from opioids since the beginning of the pandemic, but that's not the case for Black people. We've seen an incessant increase in the number of Black people who've died from overdoses. And we theorize, we have theories why that's the case. Meanwhile, overdose deaths among white individuals have declined. And then I want to talk to you about this, just mention this quote here. It says that we are continuing to see worsening trends in opioid overdoses among Black non-Hispanics, that's me, while overdose deaths have leveled off in other groups. Again, this is a direct result of the abuse that took place when this pandemic hit, or I call it the white pandemic, because there has been an opioid pandemic among Black people long before this white opioid pandemic became something that all of us talked about. Before the pandemic, I mean, before the opioid COVID pandemic, Black people weren't accessing recovery support service at the same way as Black people were, and as a result of that, when COVID hit, we just started overdosing and dying. This got kind of blurry, so I'm not for sure what it says because I can't see it, but I do want to say this. In 2004, at an all-SAMHSA grantee meeting, for those of us who are familiar with grantee meetings, SAMHSA grantee meetings, SAMHSA used to have these grantee meetings that were specific to whatever grant they funded. And then they had this big meeting where all the grantees would come together. In 2004, the late Harry Simpson, who was the founder and leader of the Community Health Awareness Group in Detroit, stood up and said, he spoke to David Thompson, who has since passed out too. He was the CSAT Center Director that worked with all the Black grantees who were funded under the Minority AIDS Initiatives, and said, David, we had 16 overdose deaths in Detroit due to fentanyl. This was in 2004. And not a single person responded. And I suspect the reason why they didn't respond is because nobody even knew what fentanyl was in 2004. We have evidence that prior to 2019, that Black people were probably dying from a rate higher, a percentage. Now, there's more white people in this country than there are Black people, so there's going to be more white deaths. But when you compare it to per 100, we suspect that the percentage was higher even back in 2004. It's not something that just happened in 2019. So this last bullet says we've got to totally bust up the narrative that the overdose crisis is a crisis mainly for white, rural, and suburban Americans. And then I tried to bold the word if that was ever true. And we suspect that that was never true. It's certainly not true today. And this is what we want to get across in the event that we run out of time. And I get the impression that I'm going to run out of time. This is the deal. This ain't rocket scientists. Because we focus all of our resources, or the majority of our resources, on white people who were impacted by opioid overdoses, we neglected other ethnicities, Black people in particular. As a result of that neglect, we now had this rising increase of Black people who are dying left and right. But in America, if I can be 100, keep it 100, like we say in my neighborhood, there's a lot of folk who ain't surprised by that. They say, David, we got a place for Black folks who use drugs. It's called state penitentiary. When Black people use opioids, it's a crime. When white people use it, it's a public health issue. Keep going, Greg.
David, we're going to pause just for a minute. We'll come back to you in a few minutes. We've been joined by Senator Murphy in person, and just wanted to turn it to the senator from Connecticut. Thank you so much for joining us, Senator Murphy. Your work on these issues, and as a champion of these issues, I say to many people, there's very few people in Congress who can have a parity conversation at the level of depth that you can in terms of policy. And we're just so grateful for your championing of recovery support services in the halls of Congress for so many years. So Without further ado, please grab the microphone. We're excited to have you. Thank you, Senator Murphy, for joining us.
Greg, thanks for having me. Just a point of clarification. Are you going to go back to David, or do you want me to introduce the people that I'm supposed to introduce?
Yeah, we can continue to go with CCAR, and then we'll come back to David.
Okay, got it. Okay, great. Well, listen, let me thank everybody for the work you've done in putting together this briefing. I love the frame here, which is all about turning policy into action. And I think that what that suggests is that, we know the right policy, right? We don't need to do a lot of additional investigation and introspection into what matters to people in the throes of addiction. It's got to be all about a recovery focus. And we've learned that in Connecticut. We've come to learn all the things that contribute to recovery, but we know we need a better partner in the federal government. So we're really hopeful that the Biden administration is going to place a really sort of laser-like focus on recovery and funding recovery. And I'm glad that you're hearing today about how you sort of take what we know and turn it into action. One of the good news stories when we're talking about recovery is that it's a pretty bipartisan issue up here. You've got members on both sides of the aisle who are willing to hear this story. And so as you're thinking about an advocacy agenda, just beg you to spend as much time talking to Republicans as you are to Democrats, because in the Senate, we still need Republican support to get some of these big investments done. I'm a member of the Appropriations Committee, and so one of the things that I care most about is recovery funding in the appropriations bill. President Biden has put what he calls a recovery support set aside into the SAMHSA account. I'd like to see us grow that, but in order to do that, we need Republicans to support us, just like Democrats, because we're ultimately going to need 60 votes for that. So continuing to support protecting that set aside for recovery and growing it, really, really important. Another thing that I'd love your continued help on, and I appreciate Greg sort of referencing it, is our work to pressure the insurance companies to do more. Recovery is really hard if you're fighting with your insurance company to get the benefit that you need, whether it's medication assisted medication therapy, whether it be counseling, whether it be in-person visits, intensive outpatient. We have been moving legislation sort of down the field that would keep insurance companies' feet to the fire, make them actually operationalize parity, right? The idea that your coverage for addiction and mental health should be exactly the same as the coverage for, an infection or heart disease or cancer. Senator Cassidy, Republican from Louisiana, conservative guy. He's been my partner on all of this, but we also need the administration to get some new tools to enforce parity. We need them, for instance, to be able to fine insurance companies that are not observing parity, meaning insurance companies that are putting up roadblocks, bureaucratic hurdles to addiction benefits in a way that they wouldn't, for an orthopedic procedure. So continuing to encourage the administration, encourage my colleagues to do more on parity. And then lastly, recovery coaches. This is something that has worked in Connecticut. What we do in Connecticut through CCAR that I'm about to introduce to you, what we've been able to do in Connecticut is put recovery coaches, people who have lived experience with recovery, next to individuals who are at a crisis moment in their life, folks that have overdosed, who for other reasons have found their way into an emergency room setting. They are put right next to a recovery coach, somebody who can guide them through that crisis, right, based on their lived experience, and then work them into the system and be a friend, be a mentor, be a guide. Our recovery coaches, they're working, but we need more federal assistance. And so I've continued to push for additional federal funding to support this recovery coach model, helping people, coaching individuals into and through their recovery, again, with people who know what it's like, and beginning that voyage. You can begin in a lot of different places, but at least making sure that everybody that shows up at an emergency room, because we know that is an identifiable moment of crisis, has that access to a recovery coach. And so that's why I'm excited to continue this conversation by introducing you to two individuals who work with Connecticut Community for Addiction Recovery. Rebecca Allen, who's the Director of Recovery Advocacy, and Kevin Schuler, who is one of these emergency department recovery coaches. He manages the program. And what I love about CCAR is that not only are they providing direct services in an impactful way, but they carve out a big portion of their agenda for advocacy. I know this because anytime that I do a forum around the state on mental health or addiction, CCAR has 1, 2, 3 people there. They have clients there, staff there. And so I hope that you hear from them and learn a little bit about their model, but also learn about the benefits of making sure that as a provider, you are reserving a piece of your time for advocacy. So with that, I'm going to turn it over to Rebecca and Kevin, and thank you very much for letting me say a few words today. Enjoy the rest of the event.
Good afternoon.
There you go.
And thank you, Senator Murphy, for your support, not just in Connecticut, but to the entire recovery community. I want to thank both Senator Murphy and Senator Murkowski for co-hosting this briefing, and to especially acknowledge the new Assistant Secretary of Mental Health and Substance Use, Dr. Miriam Delphin-Rittmon from Connecticut, for joining this important discussion today. I would also like to thank all of our elected and appointed officials that have joined us to show their support and to learn more about how vital and necessary recovery support services are in the fight to end the opioid epidemic and to stem the rising tide of Americans that are seeking help for either their own or a loved one's substance use disorder. However, most importantly, I want to express my sincere thanks and gratitude first to President Biden for including the 10% set aside for recovery support services in the 2022 budget request to Congress, and especially to Connecticut Congresswoman Rosa DeLauro, Chair of the House Appropriations Committee, for ensuring that the 10% set aside was included in the House HHS bill passed in July of this year. It's my pleasure to be here this afternoon and to provide some information on how recovery support services continue to make a difference in the lives of millions of Americans seeking or in recovery. I am a woman in long-term recovery, and what that means to me is that it's been over 23 years since I've used heroin. I share this openly with the hope that by doing so, it helps to change the public perception of how people with substance use disorders are viewed. I'm honored to work as the Director of Recovery Advocacy for the Connecticut Community for Addiction Recovery, or CCAR. CCAR was established in 1998 and is one of the oldest recovery community organizations in the nation. We provide a number of recovery support services in Connecticut, including 5 recovery community centers, a telephone recovery support program, which we've been continuously operating for over 16 years, and recovery coaching. Since 2008, CCAR's Recovery Coach Academy has been the foundational training for over 60,000 recovery coaches across the nation. Research shows that trained peers with shared experiences have a higher success rate at engaging individuals in need of help. So recovery coaches work with people affected by substance use disorders. They don't diagnose or treat addiction, but they focus on the future, helping with decision-making and plans towards recovery that will improve lives one step at a time. Recovery coaches provide support and follow through and are knowledgeable about how to access treatment, community resources, and about the multiple pathways of recovery. In March of 2017, Assistant Secretary Dr. Miriam Delphin-Rittmon, while serving in her previous role as Commissioner of the Connecticut Department of Mental Health and Addiction Services, funded CCAR to begin an emergency department recovery coach program. I want to take this opportunity to thank her and to express my gratitude for her vision and her trust in our organization to build this program from 4 hospitals to now 22 hospitals in the last 4 years. CCAR's ED Recovery Coach program utilizes a dispatch model. When an individual is admitted to an ED as a result of an overdose or other substance use related emergency, the ED staff will medically clear the patient and then call for a coach. Coaches are available from 8 a.m. until midnight, 7 days a week, 365 days a year. Our recovery coaches are skilled professionals. They attend over 120 hours of training, including the Recovery Coach Academy, ethical considerations, professionalism, harm reduction, and mental health first aid. But the coach's main objective is to make a connection with the patient. That connection is what allows them to build trust and use their training and lived experience to guide patients and their family members by providing support and connection to resources to begin recovery or to stabilize recovery when needed. Our coaches have built incredible working relationships within the emergency departments. They work in partnership with the ED staff and act as guests, deferring to hospital personnel when needed. Many times the ED staff have only experienced somebody that is actively using. They don't know what recovery is. Our coaches have been able to model what recovery looks like and sounds like. One hospital administrator shared that in her opinion, our recovery coaches have single-handedly changed the culture when it comes to how hospital staff respond to individuals with substance use disorders. The ED Recovery Coach program has demonstrated effectiveness in linking emergency department patients with treatment and community-based recovery resources. From March 2017 to February of 2021, our recovery coaches have responded to over 14,154 calls for over 9,102 individuals, with a confirmed connect to care rate of 82%. This number can even be higher because there's a portion of people, probably about 25%, that don't have a phone. So there was no way to follow up with these individuals. But I think that 82% connect to care rate is phenomenal. I want to take a minute just to kind of talk about our recovery coach team. So Greg, can you advance the slide, please? So I love this picture of our team because this is what makes this program successful, is each and every one of these coaches in this picture. And I want to reference a quote by our executive director, Phil Valentine. People don't care how much you know until they know how much you care. And these individuals care. So I'm going to turn it over now to Kevin Schuler. He is our emergency department coach manager.
Great, thank you, Rebecca. Good afternoon, everyone. I'm grateful to be here with you today. My name is Kevin Schuler and I'm a person in recovery. I'm honored to have served as an emergency department recovery coach for CCAR and currently am tasked with managing our team of 17 recovery coaches who serve in 22 emergency departments across Connecticut. Personally, this is a day of gratitude for me. 4 years ago today, my one and only child was born. Thanks to recovery, I was able to be fully present and experience the wonderful gift of being a father. But we do know that recovery is not linear. And although I first received the message of recovery over 14 years ago, shortly after my daughter's birth, I made a decision to return to use one time, which almost took my life completely and would have robbed my daughter from having a father. With recovery, I'm able to be fully involved and present for all the precious moments that come along with fatherhood. I was compelled to pursue this unique role of emergency department recovery coach due to my personal experience of being hospitalized as a result of an opioid overdose. After having my life saved with the reversal medication naloxone, being stabilized and discharged, I returned back to the same environment in which I was just pulled from. I ultimately fell through the gaps, it would return to use. Through the grace of the recovery community, I was able to access much needed resources and initiate my own recovery. Hearing that there was an initiative that would send recovery coaches into hospital settings to provide real-time support and connection to care while instilling believable hope that recovery is possible, I became deeply intrigued and began getting involved in one of CCAR's recovery community centers, ultimately pursuing and being placed into the role of emergency department recovery coach. Our recovery coaches seek to be the glue that fills those gaps that people can so easily slip into. When a recovery coach enters a room of a patient who is willing to engage, that patient is met with a skilled recovery coach who listens actively with non-judgment, empathy, and offers encouragement. They then will assist with connection to care, assistance navigating the treatment system, and education along with support to family members of the patient. The offering of in-person connection, recovery planning, and hope through our recovery coach's shared experience has immeasurable value. The need for ongoing recovery supports has never become more apparent than what we are seeing now. We are not only seeing a spike in call volume from hospitals of patients with substance use disorder, and most prevalently, alcohol use disorder, we are also seeing an increase of individuals who had a long-term recovery and unfortunately have returned to use. Many of these instances have been attributed to all the stressors and barriers that have been created by the COVID-19 pandemic. Our program is unique as it is truly dependent and maximized through the ongoing support that we offer beyond that initial hospital visit. The sustainability of recovery comes from connection. Recovery coaches can serve as a bridge to the greater recovery community and other resources with the building of recovery capital. The deep trust that can be created from a recovery coach sitting at the bedside of someone who is at a low point in their life creates amazing relationships that can develop for as long as desired. We believe that successful recovery is self-directed, and we allow individuals to design and cultivate what recovery looks like to them. We support them in their journey regardless of what pathway they choose, aiming to be all-inclusive. The positive byproducts that we call ripple effects that can come from a person embracing a recovery lifestyle is beyond measure. We see lives reclaimed and redirected. We see individuals who were once self-described as hopeless, propelled into productive, meaningful, and thriving existences. We see families and health restored, and we see the life-saving message of recovery being spread throughout the greater community. Thank you for your time. It's an honor to briefly share with you the impact that this set-aside could potentially have at a greater scale to the recovery community.
Thank you so much, both to Rebecca and Kevin, for sharing both the data and the heart and soul behind your ED Recovery Coach program. We've got a few minutes left for questions, but we do want to circle back to Dr. Whiters, David, to go for any last remarks from his presentation.
Thanks, Carol. Thanks, Greg. I'll just give a quick summation. I do want to say, though, that was a bit awkward, man. That was a little uncomfortable, but you know, it is what it is. Things happen.
So unfortunately, a standard operating procedure in DC. When senators show up, they get put on. Sorry for that it's bumpy.
No, it's okay. Just real quick, I want to say that within the many African-American communities, there's a large subset of African-Americans. We used to call them homeless people. We now call them people without housing, who make up many of these communities. Among this population, as God only knows, the prevalence of substance use. What we've learned in many of the African-American communities that we work in is that when we provide recovery support services, they have to be inclusive of the large homeless African-American community. We utilize people in recovery as volunteers who engage these people. They walk through the crowds, they tell their stories, and try to motivate them to a point where they begin to understand or see value in recovery. Many of them have had failed experiences with treatment. We don't necessarily promote treatment. We promote recovery support services. Just go to the next slide, Greg, please. And the slide before that one, yes. This one, look, one of the most important revelations that we've discovered in many African-American communities when it comes to providing peer-based recovery support services is that it's practically impossible to offer quality services to large numbers of African-Americans, particularly when you have a significant number of them who are without housing, if you don't know how to partner with the Black church. The Black church is an institution in the Black community that has been providing social support services long before any of us were born, and will be providing these services long after we are gone. It's important. We have mastered how to develop working relationships that don't discount their faith, but at the same time, don't allow them to proselytize, because that's not what we're here to do. But we utilize their services, their vans and buses for transportations, their buildings for housing, meetings, and most importantly, many of these people, the only time they will ever see a healthcare professional is at the annual health fair held in the middle of the hood, where they come and get their blood pressure checked, their diabetes screened, and they leave with some clothes and they leave with some food. It's important. This is an important part that we thought, this is just the one part that we thought was important that I wanted to make sure that we share before our time was over. But thanks again. Maybe at another time we can get a chance to do our full presentation, but we really appreciate you guys letting us be here today. Thanks.
Thank you so much, David. I think we're closing in on the time available. Before, Greg will be sending out the PowerPoint, and there's an email address on there. But feel free, if you've got some questions you want to put in the chat, we'll make sure that we do our best to get them answered. And Dr. Delphin-Rittmon, I didn't know if you had any closing remarks after you've had the opportunity to see everybody and hear everybody. Any remarks to help close us out today?
Yeah, thank you. Thank you so much for that. I mean, I just want to thank just everybody who worked on putting this, this roundtable together. It's such an important discussion. Appreciate hearing the updates from Rebecca and Kevin. Appreciated the Afro presentation. I mean, it's an important discussion, and we know that recovery support services and recovery services make a difference. And really help to change people's lives and engage people in services and supports. So know that SAMHSA is a full supporter. This is one of our overarching principles that undergird all of our priorities. So certainly this is an area of work that we are committed to supporting moving forward. But again, just want to thank the conveners, Greg, and also the representatives and everybody who joined today for this really important discussion. And thank you for the invitation for SAMHSA to be able to participate as well.
Thank you so much. And we're so pleased that SAMHSA was able to join us and that we consider you a supporter of the 10% set aside for recovery support services. It means a lot to us, and we continue to want to work with you as a partner going forward. Thank you so much.
You're welcome.
Greg, do we have time for a couple questions? Or are we going to do a wrap?
I think we're landing the plane at 3:30.
Okay.
So I think we're good.
Okay. Very good. Well, I want to thank
all of the elected people who said they were going to come showed up, and they showed up on time, Carol. So kudos to Capital Decisions for pulling that off.
Which never happens, but unfortunately that cut many of you who may have had questions. But I know I can speak for myself, and I know for Greg, if there are questions you have and you didn't get them answered, you can feel free to reach out to either of us. Greg's website is there, and I know that most of you probably know how to reach me too. Feel free to reach out if you have questions about any legislative matters. And thank you so much to all of our speakers, to our attendees, and to all those who helped make this really informative program possible today, our co-sponsors and co-host. And thank you to Third Horizons for helping organize all of it, and to my team from Capital Decisions. Thank you.